Lumbar fusion is a surgery to fuse mobile vertebrae together to decrease pain caused by the mobility of the vertebrae. This surgery may help alleviate pain in the following back conditions: degenerative disc disease, spondylolisthesis, spinal stenosis, scoliosis, fracture, infection, and tumor. Different approaches that can be used for a lumbar fusion surgery is an anterior approach, also known as anterior lumbar interbody fusion, a posterior approach known as posterior lumbar interbody fusion, or a lateral approach known as transforaminal interbody fusion. All spinal fusions use some type of bone material called a bone graft to help promote the fusion. Generally, small pieces of bone are placed into the space between the vertebrae to be fused. A bone graft is primarily used to stimulate bone healing. It increases bone production and helps the vertebrae heal together into a solid bone. Sometimes larger solid pieces are used to provide immediate structural support to the vertebrae. An autograft, allograft, or artificial bone graft can be used. Autograft is generally used by taking a piece of your own iliac crest. The development of a mobile vertebrae can be caused by overuse, genetic, infection, accident, or trauma caused to the joint.
A posterior lumbar interbody fusion, called a PLIF, is a surgery designed to stop the motion at the targeted segment of the spine. A PLIF is done in the lumbar, or lower spine. Most commonly, it is performed on the L4 through L5, or L5 through S1 segment at the bottom of the lumbar spine. This surgery may be done to treat lumbar degenerative disc disease, in which a degenerated disc becomes painful. It may also be done for a lumbar spondylolisthesis, in which one vertebra slips forward over the vertebra below it. A PLIF starts with a 3 to 6 inch long incision in the midline of the back. Next, the lower back muscles, called erector spinae, are stripped off of the lamina on both sides and at multiple levels. The lamina is removed, which allows visualization of the nerve roots. The facet joints, which are directly over the nerve root, may then be trimmed to give the nerve roots more room. The nerve roots are then retracted to one side, and the disc space is cleaned of the disc material. Some type of implant, called a cage, is then inserted into the disc space. The cage helps restore more of the normal spacing in between the vertebrae, alleviating pressure on the nerve roots. Bone graft is placed in the cage and along the sides of the spine. There are many bone graft options. If the patient's own bone graft is used, bone morsels are harvested from the patient's iliac crest along the back of the hip. This is an additional surgical procedure that is done at the same time as the fusion surgery. Bone that has been removed from a laminectomy may also be used, or synthetic bone graft options may be used. The surgeon may implant a series of screws and rods to the back of the spine for additional support. A PLIF fusion may be supplemented by a simultaneous posterolateral spine fusion surgery. In addition to open surgery, a PLIF may sometimes be done through a tube in a minimally invasive approach.
The ALIF is defined as anterior lumbar interbody fusion. This approach requires a 4 to 6 inch incision in the abdomen to access 1 or 2 levels. The surgeon works around the large vessels to access the anterior longitudinal ligament. The ligament must be removed to access the disc. The surgeon can then remove the diseased disc nucleus to prepare the vertebral bodies for fusion. After the disc is prepared, a biocompatible polymer implant is filled with bone graft material and placed in the disc space. With an ALIF implant, the surgeon may choose to add an anterior plate to replace the anterior ligament and prevent movement of the implant. This procedure is normally accompanied by a posterior fixation with pedicle screws or facet screws. The implant maintains the spacing of the vertebrae while the fusion takes place. After the fusion is completed and a solid bone mass forms, the two vertebrae are joined together.
This is our case today. This is a patient that has back pain with spondylolisthesis. The L4 vertebral body slips forward on the L5 vertebral body. So we're going to go in anteriorly and do the anterior lumbar fusion that you're familiar with from prior videos. Then we're going to go posteriorly and connect the spinous processes together with a tension band called an interspinous device. We'll show you how we do that today. What an interspinous device does is it clamps onto the spinous processes to secure them and create a tension band. With a patient on his or her belly, we'll make a small incision, open down to the spinous processes, those bones that you can feel in your back. Take out the ligament between the two that you want to secure together, and then simply drop this down into position. Loosen the nut that's securing it, and with a set of crimpers, crimp it together on the top and on the bottom, and then tighten the lock nut, and you'll be finished. So the device is now in between the L4 and the L5 spinous process. We're going to get it positioned, clamped into place, and then not only will she have stability in the anterior column, but she'll have a posterior tension band, and at the same time I will do a facet fusion, minimizing the amount of muscle dissection, and give her stability anteriorly and posteriorly. So you saw the MRI showing the spondylolisthesis. Now you can see the spondylolisthesis has been corrected anteriorly. We restored the alignment from anteriorly, put in the fixation device, and then posteriorly put in the interspinous device. Now aligned well, no more stress on that level, and this should help significantly with her back pain.
After discharge from surgery, the patient should avoid shifting positions frequently, sitting, standing, or lying down for long periods of time, bending, twisting movement, and lifting heavy objects, no more than 8 pounds. Short walks and gradually increasing activities encouraged, but should be stopped if the pain increases too much. Medication prescribed by the doctor may be used. The incision site should be cleaned daily and checked twice a day for any sites of infection. Signs of infection include fever, chills, redness, swelling, and discharge around the incision. The doctor should be contacted immediately if there's any signs and symptoms of infection. From 1 to 4 weeks post-surgery, infection is the biggest concern during this point of recovery. The patient should be aware of any signs or symptoms of an infection. Exercise is important to the healing process. The patient should continue to gradually increase exercise. Walking is encouraged but should be stopped if the pain is intense. The patient should also begin to wean off the pain medication. From 1 to 3 months post-surgery, the fusion process is critical. The lumbar fusion bone mass is becoming established. Excessive lifting, bending, and twisting should still be avoided. The worst pain from the surgery should be over with. Pain should continue to gradually decrease. Physical therapy may be started during this time to help increase activity. 3 months and after. Exercise is an important component during this process of rehabilitation. The patient should concentrate on strengthening the muscles that may have been compromised during rehabilitation and increasing range of motion. The patient should be enrolled in a long-term exercise program that includes stretching, strengthening, and aerobic conditioning. Excessive lifting, bending, and twisting should still be avoided. It takes about 8 months for full recovery from the lumbar fusion surgery. The bone continues to evolve from 12 to 18 months.